So, hey, Tony, good to see you, even though we're, as usual, not in the same room, but seems like we've spent more time on Zoom talking to each other or on the telephone every night when we're catching up on stuff. Yeah. Nice to have a chance to talk about all this for the Friends of Cancer Research. How you doing?
I'm doing fine, Francis. For those who don't know, that Francis and I now see and talk to each other literally every day, sometimes twice a day. So the fact that the NIH leadership is very heavily involved, not only in coronavirus research, but all the other implications and spin-offs that have occurred because of that. So here we are.
Here we are. So, Tony, this is a 25th anniversary of Friends of Cancer Research, this remarkable organization that has done a lot to advance the cause of cancer research and clinical trials and advances that we're all pretty excited about, all of which have taken a hit like everything else this year, with COVID-19 becoming such a prominent part of our agenda and keeping people from necessarily working in the lab the way they might like to, just for safety reasons. Maybe we could just start out and just provide a little bit of background about why has this pandemic been so different than other things that you've worked with in your 36 years leading NIH's infectious disease enterprise like H1 and N1 and Ebola and Zika. Why has this one become so completely consuming of all of us?
Well, Francis, you know, it gets back to what you and I have spoken about over the years. We used to have conversations where you would ask me, Tony, from an ID standpoint, what would be your worst nightmare? What would be the thing that keeps you up at night? We've gotten asked that at cocktail parties and at congressional hearings. They ask us the same question. Well, you know, what it is I've said it, and unfortunately now it's come true, is that the concern is that you have a brand new virus that the population of the world has had no experience with, jumping species generally from an animal, that's a respiratory-borne illness that has two confluent characteristics. One is that it's highly, highly transmissible from person to person, and two, that it has a high degree of morbidity and mortality, either in the general population, which would be horrible, or for a selected group for which is particularly serious. And we've seen versions of outbreaks that have had one or the other of those characteristics, but not both of them. But then when you put them both together, you have a virus that has jumped species from an animal reservoir. It has immediately has the characteristic of incredible efficiency of spread from human to human. However, it also has a high degree of morbidity and mortality among the elderly and those with underlying conditions. And we know that now. The numbers speak for themselves, Francis. We now have tens of millions of infections worldwide, going right up to about 1 million deaths. In the United States, 6,700,000 infections. And tomorrow, we will have 200,000 deaths. It's 199,745 as of the last thing that we said. So by the time that people will be listening to what we're saying, it will be over 200,000. So that's something that is devastating because the only way when you don't have a vaccine of stopping something that has such incredible efficiency is to shut down, to shelter in place. That is unsustainable for an indefinite period of time because it will crush the economy, which in many respects, it already has severely damaged the economy, damaged not only the economy, but what you mentioned, research coming to a halt, cancer screening slowing down, HIV drug delivery slowing down, testing for colon cancers slowing down, mammograms slowing down. We've got to get back to some form of normality. And I think the only way we're going to do that, Francis, is a combination of both a safe and effective vaccine and continuing some aspects of public health care. That may be masks for another year until we get the population vaccinated. So it's really unprecedented, Francis.
Yeah, so talk a little bit more about what we have in store for us coming over the next few months. First of all, let's say that the scientific progress on therapeutics and vaccines has been unprecedented, bringing together partners in the public and the private sector, doing things through warp speed on vaccines that has never been attempted at this speed and scale before. But even in the best of all outcomes, you just mentioned, we're probably not going to be all done with this in January. So walk through what would be, a realistic perspective so that people listening to this can kind of get themselves prepared.
Okay, so as you well know, since you're deeply involved with us, we now are involved in either development of or facilitation in the testing of at least 6 candidates, 3 of which are already in phase 3 trial in really extraordinary speed. Remember, the sequence of this virus was only made known on January 10th. We began work on the first vaccine on January 15th. 62 days later, we were in phase 1 trial. 6 months later, we were in phase 3 trial. Right now, we have 3 phase 3 trials. One is on hold now because of a serious adverse event that occurred in the UK, but 2 of them are going right now full speed. One will join in another week or 2, another in another month or 2. But let's look at the 2 that are already in phase 3 trial and are almost fully enrolled. We project that given the number of infections we're seeing and the number of people in the trial, it goes anywhere from 30,000 to 44,000 to one trial projects 60,000 people in the trial, that we will have an answer whether we have a safe and effective vaccine, I would say by November, December. Is it possible we'll know in October? Certainly it's possible, likely November, December. What has happened that is totally unique is that all of the companies have been given literally hundreds of millions, if not billions of dollars to produce vaccine at risk so that by the time we get to a point where we have knowledge that we have a safe and effective vaccine, pick your month, October, maybe unlikely, November, December, January, we already have in place the doses that are going to be ready to be distributed. Now, even though we have hundreds of millions of doses and will, in the combination of all the companies, will have about 700 million doses, which is most of them are prime boost. So 328, 330 million people in the USA, we could theoretically vaccinate everybody. There are a couple of issues with that. The first is that all of those vaccines have to be approved in order for them to be released from the stockpile where you have it into the pharmacies and the distribution places. So you can't say we have one vaccine that gets approved. You don't have 700 million doses of that vaccine. You have 700 million of the total of all the vaccines. So we're going to have multiple vaccines in play. One of the issues that people don't appreciate is that even though theoretically you could vaccinate everybody in a couple of months, the fact is we know from experience that people, even with a vaccine that you would think they really feel they need, the hesitancy for everybody to get vaccinated until you see we have 20 million, 50 million, 100 million, and things look good. The infection rate starts to go down a bit, not completely, but it goes down a bit. There are not a lot of effects that people worry about. Then everybody's going to start to want to get vaccinated. That likely won't take place completely until the end of the first half, the beginning of the third quarter of 2021. Mm-hmm. Now, one of the questions that people have asked, when we get there at that point, unless you have a measles-like vaccine, which is 98% effective, let's say you have a 70% effective vaccine, you have to be careful because that means you can't completely abandon public health measures. It's going to be a combination of public health measures and a good vaccine. Let's say 70% we consider will take that. That's a good vaccine, which means 70% of the people who get vaccinated are protected. You may have a lot of people who don't want to get vaccinated, which means numerically, you have some people out there that are vulnerable. And particularly a vaccine that can be very serious. I mean, a virus that can be very serious for the elderly and those who have underlying conditions. We may not get back to a degree of, quote, normality until the end of 2021, even though we've done rocket speed in getting the vaccines.
Well, that's realistic, maybe a little sobering to people who just want this to be over, but we have to think and plan accordingly. In terms of what this does for research, Tony, because obviously you and I are both grieving, I think, a bit about what's happened to the rest of our research engine, having to send our researchers home for their own safety, and even now at NIH, letting people come back, but very carefully so that they maintain physical distances, they wear masks all the time. My own lab is sort of running shifts so that people can do some work, but they're not all there at the same time. And many people are going slowly because, they're only there 3 days a week instead of 6 or 7. When do you think we might be able to start to really activate again the full court press on all of the other research challenges? Well, let's talk about cancer, because we're speaking to the Friends of Cancer Research, and get that back where it needs to be to make progress, because we were making progress and then this came along and everything had to go slow for a while.
I think we could safely do that because we have a population of workers here, our colleagues, who take this very seriously. And we know that we could probably get back with things like mask wearing and not congregating together a lot and still get people back in the lab more safely. Because once we start vaccinating people, I would think by the end of the first half of 2021, we can see what we're doing almost back to normal. That's different in whether you're going to get people crowded into a theater or you're going to have a big reception where people are going to want to be without masks. I think we could do our work with masks at a much more extensive level than we're doing now by the end of the first half of 2021.
People are trying to look at silver linings here, and goodness knows it would be great to discover some. And one in the delivery of healthcare has been how telemedicine has been adopted at a much more rapid pace than it was before, because it was in many instances the only option where you could deliver healthcare. And we've seen that taking place in things like, for instance, the addiction centers where they couldn't have people coming in, yet they're still taking care of people, but also in just primary care. My daughter's a primary care doc in North Carolina, and she's just as busy as ever, but she hardly ever has a patient in the same room with her. But do you think there are going to be long-term consequences of this kind of shift in the way we do research and the way we deliver healthcare? Because we won't really want to go back to the way things were. We'll figure out there's some more efficiencies here.
No, I think we will. Francis, there is always the advantage of being person to person when you want to develop collaborations. But the one thing that I'm realizing now, who had never done any Zoom at all, I as you well know, I'm not the computer geek that I'd like to be, that there are things that we can do to save a lot of time. Because sometimes, Francis, you and I make trips, and when we're there, we could just as easily have done it this way, the way you and I are doing it. There are certain things you really want to be in the same room. You want to develop a collaboration. You want to go out to dinner with the people, solidify the things that you and I have done through the years of our career. But there are certain things that really don't require that. They just require people chatting with each other and setting up screen sharing and taking a look at data, which I find in some instances works just as well. I don't want to give up the contact that we have, but I think a lot of things that we do, we may wind up getting more efficient. If you think about the amount of time you spend going to an airport, waiting to board, waiting for the delay in the flight, flying there, getting to the hotel, waking up and have a meeting, when you could just do it this way. You don't want to do everything that way, but I think there's going to be not only telemedicine, I think in some respects, scientific communication might actually get even better when you could save some time like we're doing right now.
Yeah, no, I have to agree. I have not missed all those hours that I would normally be spending on airplanes and in strange hotels where I never get to sleep very well anyway. So this is probably, it's unleashed us, hasn't it, to work even more hours every week, like I know you are, and I guess I am too, here in my home office in Chevy Chase. Well, Tony, run the clock forward a little bit. Let's say it's now 2023. And what do you think things will look like at that point as far as medical research? Are you going to be willing to make a projection about what infectious disease challenges will be in front and how will they be dealt with?
Well, I think if we have a corporate memory of the kind of preparedness that we should have had for this, some was good. I mean, I think the platform technologies that many of our colleagues here at NIH have developed have allowed us to do things in months that took years to do. But I think that we need to have a better health systems that can handle at the local level things that we don't handle very well right now. But if I look ahead and I look at the technologies that we've developed, Francis, I think, for example, if we get an HIV vaccine, that'll be fine. It's going to be very difficult for a lot of reasons that you and I have spent a lot of times discussing. But the thing that is extraordinary is what we're seeing with long-acting PrEP. In other words, things that you could take an injection every 6 months and sometimes once a year while you are in a risk situation. I think that that would be almost as good, if not better, than a vaccine. So I think we're going to see an extraordinary turnaround in the number of cases of HIV. Secondly, I'm very pleased, and this was unfortunately interrupted by COVID-19, the advances that are being made in vaccines for both tuberculosis as well as in malaria. So as you know, you and I had a long conversation when you became the director of the NIH and you put together your goals, and I remember it well. One of them was global health, and you and I had the conversation that if we could walk away from this place with vaccines for the three big killers, HIV, tuberculosis, and malaria, that would really be a good feeling. I think we can be close to that in 4 or 5 years from now. I do. I really do.
Well, that would be indeed wonderful. I know people listening to this also wondering about other areas of research. Where will we be? I just would say, as we get the chance to unleash all of that capability, I think we can also build on some of the relationships that have been strengthened as a result of COVID-19. Certainly some of the things we've done across academic centers in terms of our partnerships with industry through the ACTIVE partnership, which has been amazing, with 20 pharmaceutical companies working in a seamless fashion with NIH and academic centers and CDC and FDA and the Veterans Administration and the DOD and all of that, managed very capably by the Foundation for NIH. Those kinds of frameworks for moving research forward more quickly, since they have worked so well, I hope we can continue to adopt them. And for cancer research, I've been so excited about the progress that has been made with genomics and the way in which that has allowed us to begin to practice precision medicine for the selection of the right drug for the right person at the right dose in the right time, but also the cancer immunotherapy revolution, which I think still has a great deal of excitement in front of it, and figuring out exactly why does it work when it works and why does it not work when it doesn't, and how can we take immunotherapy even beyond where it has been so powerful for things like melanoma and leukemias and lymphomas, and get it to work for solid tumors. There's no reason I can see why that is not an achievable goal. In 3 years from now, I think we will probably have made a lot of progress in that space if we can just unleash the power of our remarkable research community by getting them back into where they want to be, working on these problems.
Well, one of the things I can think of, Francis, that we need to pay attention to, I mean, there are the big things like vaccines and therapeutics, but there's something that has informed all of that, and that's what we call the pathogenesis of the disease. I'm getting concerned about the longer range effects of people who have a mild to moderate illness, where they may be in bed for a week or 2 or 3, how long symptoms last. Something like the brain fog or the difficulty concentrating, myalgias, fevers, all when they're viral negative. This post-viral syndrome, more and more people that you question have that. The other thing that I think is going to be important is that a couple of studies have come out that's quite disturbing to me, that they looked at individuals who had clinical disease, some moderate, not even requiring hospitalization, and some in the hospital, where after they recovered and were relatively asymptomatic, in a paper that was published from Germany in JAMA Cardiology, they did MRIs on their heart and found that 60 to 70% of people had evidence of inflammation in the heart. Now, they weren't symptomatic with it, but you have to be careful because those are the things that could lead to arrhythmias unexplained in the future, coronary artery disease unexplained, importantly, cardiomyopathies. So we are doing at the NIH long-range studies of follow-up of individuals for years after they recover, looking specifically at things like cardiovascular and neurological abnormalities. So in addition to the get better or die situation, there's a big in-between thing there that we better be humble enough and modest enough to realize we still have a lot to learn in addition to developing vaccines and to developing therapies.
That's a really important point. I guess if I had to pick one, although people have heard about it, I don't think they've heard enough about it, is how this particular disease has hit certain communities with a particular vengeance. And that's particularly people who have chronic illnesses, the elderly, but it is also people who live in the lower socioeconomic status situations. And that particularly applies to a lot of African American and Latinx communities. And this is shining a bright light on something which we have been aware of, but maybe haven't paid enough attention to, which is that our healthcare system in this country is riddled with health disparities and health inequities. And here comes this disease along, and it makes it so clear that not everybody has the same access to the opportunity to stay healthy. We need to learn from that. We need to move swiftly to identify ways to try to protect those particular communities from things getting even worse. And we have programs right now to try to be sure we're getting diagnostic tests that are point of care out there to be able to quickly identify who's infected and isolate them so that these diseases don't spread the way that the COVID-19 has. But we also need to use this as an opportunity to recognize the way in which our whole system needs a revamping when it comes to the equities or the inequities of healthcare. We need not to miss this moment to act upon that.
Totally agree, Francis.
Tony, you have been such a gift to the public, to NIH, to the world, and this incredibly challenging, difficult time, the worst pandemic in more than 100 years. And I am grateful to you, and I know everybody listening is, for your stance of speaking the truth about what we know and what we don't know, as well as your remarkable scientific leadership of trying to be sure that everything we could think about in terms of tackling COVID-19 is happening through your remarkably capable staff and all the relationships that you have nurtured over the years. So we are truly fortunate at a crisis like this to have a leader like you. I know it wasn't part of your plan for 2020, and it wasn't mine either, but I'm glad you are in the middle of this, directing it in such an effective way. With that, I will sign off, and thank you, Tony, and let the Friends of Cancer Research have at you.
Thank you very much, Francis. It's been a great pleasure working with you, and I look forward to the continuation of this partnership. And just, remember, I think you and I have been around long enough to realize that some of the things that we thought were unimaginable and impossible a couple of decades ago have come true. So I think when you talk about advances in cancer research, infectious disease, neurological diseases, there's nothing that is beyond what I think science can do. So we just got to keep plugging away. All right. Thanks a lot, Francis.
All right. Thank you. Bye now.